We will quickly move over to our next session, and that is by Dr. Shashi Lata Kabra, an internal iliac ligation. And for that, may I invite, we have past presidents of Patna Obs and Gynae Society, Dr. Kumkum Sinha ma'am, and Dr. Neelam ma'am. And along with that, we have our moderator, Dr. Usha Sharma ma'am. Dr. Usha Sharma ma'am, you are moderator in this workshop. Please come over the dais. So we have the blessings of all our past presidents of Patna Obs and Gynae Society, and it really means a lot to us. We have been working under their guidance. Again, invite Dr. Abharani Sinha ma'am, our co-convener, to come over.
Good afternoon, everybody, and thank you so much for giving us this opportunity to chair this important session. It is my proud privilege to introduce Dr. Shashi Lata Kabra Maheshwari, Madam. She has been awarded IMA Appreciation Award, recipient of Wonder Foxy Award 2019, APJ Abdul Kalam Appreciation Award, IMA WDW Karamveer Award, Champions Award Obstetric Critical Care 2021. Again, APG Abdul Kalam Excellence Award in DGF 2022. DDU Hospital Best Doctor Award. I mean, she has so many awards. And latest perhaps is organized 82 workshops on PPH all over India. That's a very commendable thing. And she's associate of prestigious RCOG and patient right of teaching model on IIAL. So, she will be speaking a life-saving procedure for intractable PPS, that is internal iliac artery ligation. And Madam, floor is yours. Please start.
Good afternoon. Thank you so much, ma'am, for such a kind introduction. And first of all, my heartfelt thanks to Patna OBG Society, Dr. Meena Saman, Dr. Amita Sinha, and National Convener Foxy, Dr. Bhaskar Pal, and whole Foxy team for having me here. So, internal iliac artery is a life-saving procedure. And in order to save life, we have to learn this. So, with our anatomy classes in first year, you can see here, the biggest vessel in our body at the level of L4 and L5, it divides into two common iliac arteries. And each common iliac artery in succession divides into external iliac artery and internal iliac artery. The lumen of the external iliac artery is bigger and that of internal iliac artery is little smaller. And this level is at L4, L5. Then this insect had been shown here. Here you see this is one-sided common iliac artery. This is lateral side, this is medial side. This common iliac artery divides into external iliac and internal iliac. And internal iliac artery, just after its origin, gives the posterior branch. And we have to ligate this. So, the posterior division, as sir had said, are parietal branches, and we are concerned with the anterior division. And the most important arterial supply is uterine artery. Uterine artery bleeds 800 ml per minute during postpartum hemorrhage. So we have to control the bleeding in 7 to 10 minutes. So this is the collateral circulation. Now coming to the relations, anteriorly there is peritoneum. We call it retroperitoneum. जब हमको internal iliac करनी है, तब हमको retroperitoneum खोलना पड़ेगा. Then medially we have ureter. Gynecologists are always afraid of ureter. भाई ureter से नहीं डरिए. Ureter lies in the medial flap, such a goody structure कि भाई मैं तो medial flap में हूँ. You do whatever you want on lateral side. Then inferomedial, we have internal iliac vein. Laterally, we have psoas major muscle and internal obturator muscle. And inferolateral, we have obturator nerve. Now, this is one picture of after dissection. This is external iliac. This is internal iliac. I'll show you my own video. So, how does it work? Bilateral internal iliac artery results in 85% reduction in pulse pressure and 50% reduction of blood flow. So basically it converts an arterial blood flow into a venous flow, and thus coagulation is facilitated. Bleeding is reduced and the life is saved. Technically it is difficult initially, but one picks up it very easily. तो मतलब आज का मैसेज ये है कि हम सबको इंटरनल iliac artery ligation सीख के जाना है. So latest FIGO guideline 2022, it recommends internal iliac artery ligation as one of the options to rapidly control postpartum hemorrhage for management of postpartum hemorrhage when medical non-surgical approaches and compression sutures fail. FIGO also recommends that all obstetricians familiarize themselves with the internal iliac artery location and with the technique of its ligation. अब एक दिन में तो सीख नहीं जाएंगे internal iliac artery. हम कोशिश करते हैं आज हम location सीखें, anatomy सीखें, technique सीखें और धीरे-धीरे we will go on. So there are two approaches, with uterus, without uterus. If hysterectomy is done, we can perform internal iliac artery ligation. If uterus is there, we can also perform internal iliac artery ligation. Those situations हमारे पास we have uterus present or not, and the approaches are two again, anterior approach and posterior approach. When we bring the uterus forward and open the posterior peritoneum, then it is called posterior approach near the pouch of Douglas laterally. And when we make a nick through the round ligament, then it is called anterior approach. These two are my best companions for performing internal iliac artery ligation. This is mixture forceps. In the evening at 5 to 7 p.m. in my workstation, I will show you this mixture forceps. And yeah, what is this? This is a thread number 1 silk, which is just doubled. And it really causes magic. So this is my video. When I used to be called in my labor room where we have 10,000 deliveries per annum. Then every time when I used to do internal iliac artery ligation, new batches of residents used to come and nobody knows what to do. They don't even know the anatomy. So that struck my mind and I made a model for this, at least to show them what actually internal iliac artery ligation is and what the anatomy is. Internal iliac artery is a retroperitoneal structure, and in order to ligate the internal iliac artery, we have to work in the depth of the abdomen. So that's why I have given to work in the depth of the pelvis. Now, thinking this is the abdomen and abdomen opened, now we are inside the abdomen. So in order to ligate the anterior division of the internal iliac artery, we have to open the retroperitoneum. So after pushing the uterus anteriorly, we look at the retroperitoneum and we have to open the retroperitoneum. Now there are two methods of opening the retroperitoneum. One method is make a nick on the peritoneum 2 cm below and 2 cm lateral to the sacral promontory and enlarge that nick and open the peritoneum. So we will reach the bifurcation of the great vessels, bifurcation of the common iliac artery. And second method is, which is more commonly used by me, is make a nick in the middle of the round ligament in the peritoneum, and then from that nick proceed up to the base of the infundibulopelvic ligament, gently cutting the peritoneum about 7 to 10 centimeter, and then open that retroperitoneum. This can be opened with the uterus being there and even after the uterus is removed. And how to open the retroperitoneum? Once you have opened the retroperitoneum, then there will be two flaps, one medial and one lateral. This is the medial side and this is the lateral side, and medial flap always has ureter. So when you do internal iliac artery ligation, never get afraid of ureter, because ureter always remains in the medial flap. And this is the lateral flap. And how to see the structures below the retroperitoneum? You keep all the instruments aside, and just after opening the retroperitoneum, there is loose areolar tissue, so you just separate it with your finger movement without taking any instrument. And then you will see the bifurcation of the common iliac artery. This is inverted Y. In order to ligate the internal iliac artery ligation, the first important step is open the retroperitoneum in the vicinity of the great vessels. Second thing is recognize the bifurcation. Unless you recognize this bifurcation, we can't proceed anywhere. This looks like an inverted V, inverted Y. This is common iliac artery. This is showing only one side of the great vessels. This is lateral side. This is medial side. This is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and the internal iliac artery, just after its origin, this iliac artery just after its origin gives origin to the posterior division, and the anterior division is continued. We have to ligate the anterior division of the internal iliac artery in order to reduce bleeding from postpartum hemorrhage. So we have recognized the bifurcation. Now we have to recognize which one is internal iliac artery. External iliac artery is a lateral structure and internal iliac artery is a medial structure. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go, because femoral artery is a continuation of the external iliac artery. And when we release this pressure, the femoral pulse will come. So this is how we recognize external iliac artery. When we apply the same pressure on the internal iliac artery, there will be no change in the femoral artery pulsation. So this is how internal iliac artery is confirmed. So we have recognized internal iliac artery. Now our next thing we have to do is we have to recognize the site where the artery needs to be ligated. Now how to identify the anterior division? Normally in the pool of blood, this posterior division is not seen. But you see here that this posterior division is given very soon after the origin of the internal iliac artery. And if we measure the distance from here, then see from the bifurcation, within 3 centimeter, this branch of posterior division is given out. So we can safely ligate this anterior division of the internal iliac artery 3 centimeter below the bifurcation. So now it is clear. In live surgery, how will we identify this? See, if I place my thumb here, then the length of my folded thumb is around 3 centimeter. So I just put my thumb here at the beginning of the bifurcation and around 3 centimeter. This is the place where I can recognize the internal iliac artery needs to be ligated. So now I have identified the site also. Now next is how to do the dissection. Before that, I'll show you this instrument. This is right angle forceps, also called mixture forceps. It is bent at 90 degree and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. So how to proceed for dissection? See, there is a sheath-like structure. I have used my kitchen cling film to give the appearance of the sheath. It covers all the vascular bundles. Like both this is internal iliac vein, this is internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. This is my proposed site of ligation. This movement is parallel to the vessel. So I am separating it like this. Now I have separated this. Now next step is I have to pass a silk thread. I use number 1 silk below the artery. And one very important thing is that when we have to pass the right angle forces from lateral to medial on both the sides. Lateral if I pass from medial to lateral, then again there are chances of injuring the internal iliac vein. So this movement will always be from lateral to medial. And one more important thing, the wall of the artery is thick and the wall of the vessel is very thin. So when I pass this, then I will graze through the lower surface of the artery. My movement will be against the artery, not towards the vein, because if I make it like this, then I will puncture the vein. So these are 2-3 precautions and important points. Now I will pass this right angle forces at the proposed site of ligation from lateral to medial, and my assistant will show me a silk thread. Look at the thread. This is a silk thread. Number one. Just how I make the silk. I made it double, making a loop like this, and my assistant will give this to me. I have already made a place here for ligation, passing the right angle forces from lateral to medial. You can see loop is already there, ready. Gently I will open it, and I will get hold of the loop, and just gently I will come out like this. Your instrument is grazing through the wall, the wall of the artery. Now next step is I will cut this and make 2 threads. So with one instrument movement I made 2 threads. Can you appreciate this? Now my assistant will help me in identifying the threads. So this decreases the chances of injury to the vessels. Yeah, I've done it. This is one thread, and this is another thread. See, this is plain and this is another thread. Now I have to apply 2 ligatures, 0.5 to 1 mm apart. So look at the technique of applying ligature. So we apply 2 ligatures. Now look at the technique. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is
Two
second
turns
turn.
in the first
And I've
knot.
tied it here.
Very
Then
good.
very gently I applied the second throw,
Then like it.
and again very gently I applied the third throw. Without pulling the artery, I myself cut this.
Never pull the
Just
artery.
without giving
Go
any
up to
pull
the
on the
artery.
suture, I cut this. Now taking the second thread, this is 0.5 to 1 mm away. I made one turn and two turn. This is a square knot, and I applied the suture here.
This is how.
Again, I am
yes,
not pulling the
0.5
artery. I am
centimeter
going
apart.
up to the superior surface of the artery.
So, the very important message is that you have to pass, as Dr. Bhaskar Pal has also said, pass the right angle forceps from lateral to medial. Lateral to medial, lateral to medial, and lateral to medial. Because if we go reverse, then we will injure the external iliac vein. So now this is a real case. Maybe I might be taking more than 2 minutes more, but I have to share this. This was a 26-year-old primary gravida with full-term pregnancy, booked initially in one facility. Then she had ANC at one Anganwadi center. Then she had labor pain on 23rd November 2022 and rushed to 3rd hospital at night, went into obstructed labor, taken to another 4th private hospital, undergone emergency cesarean section for second stage arrest under spinal anesthesia at 8 a.m. And she had an episode of postpartum hemorrhage at 10:15 a.m. and which was managed medically. So delivery at 8 a.m. and postpartum hemorrhage at 10:15 a.m. they noticed. Then she had again second episode of postpartum hemorrhage at 12:30 p.m. and she developed shock. So they took her to OT, and under saddle block anesthesia, the obstetrician did left lateral cervical tear repair and a posterior vault repair. And she was given 1 unit of PRBCs and further 4 units of PRBC, 4 FFP and platelets. Then after 11 hours at 7:15 p.m., the patient went into shock again. And she was resuscitated and referred to me with 5th unit of PRBC on flow. So when we received the patient, her pulse was 146, BP is looking normal, 104/60. But when you see in depth, her shock index was more than 146/104. And her uterus was soft, per abdomen was soft and uterus contracted, per vagina there was significant bleeding. I took no time in making the decision of opening the abdomen in this case. So I opened the abdomen with the right paramedian incision, and there was a huge broad ligament hematoma on the posterior surface extending from the fundus to the colpos. So we performed the hysterectomy in that case. And now after hysterectomy, there was slight oozing here and there, so we performed an internal iliac artery ligation. This is a real case, and the video is unedited. From incision to the procedure, less than around 6 minutes. Just watch this. So here I will go through round ligament pedicle. Hysterectomy done. This is round ligament pedicle. Can you appreciate this? Please, all lights off. This is the peritoneum from the round ligament pedicle, which I am cutting and moving laterally, parallel to the infundibulopelvic ligament towards the lateral pelvic wall. Please put off all the lights. So can you appreciate this? The thin peritoneum I am cutting without injuring the structures which are lying below. Now I've kept all the instruments, and with my 2 fingers, I am opening the loose areolar tissue. At this moment, you should not have any instrument in your hand. This is the inverted Y which I am going to see. Because of lights, this resolution is not seeing that good.
No, it is.
Visible? Okay. So this is common iliac, this is external iliac, this is internal iliac. This is inverted Y, you can appreciate, I think. External iliac, internal iliac on internal side, and this is inverted Y. जब तक आप inverted Y को नहीं देखते, तब तक कुछ नहीं करोगे आगे. You have to make the inverted Y prominent. Now you see how I am doing it. Can you see it now? Please tell me whether you can see or not.
Yes.
Yes. This is, now I am pressing the external iliac artery and seeing the femoral pulse. It goes, and on lifting the pressure, it comes. Then again I am pressing the internal iliac artery, and there is no change in femoral pulse. So it is doubly confirmed. Now I know that this is internal iliac artery, and I know that I have to go 3 centimeters below. Only at that place
I will start ligation. So the movement of my mixture forces parallel to the vessel because the internal iliac vein and artery, they both are enclosed in a sheath. So then you have to cut the sheath. You have to make a space between the artery and the vein. So this is what I am doing. You just see. The assistant is beautifully cutting it. Again. So I am not doing dissection along the whole length of the structure, only at the proposed site of ligation, which is 3 to 4 centimeter below the bifurcation. आप जितना लंबा उसको डिसेक्ट करो उतनी जगह आपकी इंजरी की चांस बढ़ जाएगी. नाउ दिस इज गोइंग lateral to medial, and और your instrument will graze through the artery. आर्टरी जितनी मोटी होती है, जितनी बड़ी होती है उतनी मोटी होती है, वेन जितनी बड़ी होती है उतनी थिन होती है. Now the loop has to be kept already ready. So the loop has been taken. Purpose of loop क्या है कि with one movement of this instrument you can make 2 threads. 2 movement instrument के करोगे तो there will be double chance of injury. So now it has been cut.
Madam,
Yeah. Right, right. Yeah, yes, ma'am. Yes, yes, yes. Definitely. So very gently you have to separate the threads, that which one is continued with which one. This is an unedited video that in grave emergencies, don't get panic and do this. So now I am applying the first ligature, 2 turns in the first knot and next 2 knots in reverse direction. Don't pull the artery. Bend your back and bow your head. Just put the knot on the surface of the artery. You are saluting the artery. It is the one of the biggest vessels of the body. तो आर्टरी को सैल्यूट कर दीजिए. Now without pulling the artery, you cut it. Can you remove this? Okay, okay. Yes. So without pulling the artery, you have cut it. Can you see the first ligature in place? Here. Now second ligature is being, it is 0.5 to 1 centimeter away from the first one. It doesn't matter which one you make first and which one you make second. And you have seen here that posterior division is usually not seen in a pool of blood. So posterior division को देखने के लिए मत कोशिश कीजिए. Just go 3 to 4 centimeter below the bifurcation of the common iliac artery. So the second, you just see a bulge, beautiful bulge between the 2 sutures. Can you appreciate this? Please tell me. So the internal iliac artery, we apply 2 sutures. We never cut it, remember. We never cut it. It is just like this. Only 1 minute, only 1 minute. So now you see internal iliac artery with 2 ligatures, external iliac artery, and this is common iliac artery. Thank you. Ma'am, yeah. Yes. Ma'am, एक slide मेरे को और बोलने दीजिएगा.
हाँ जरूर जरूर.
So I have performed more than 110 internal iliac artery ligations in last 22 years in Dindal Upadhyay Hospital, and these are my own tips, not copied from any of the books. Open retroperitoneum from round ligament to infundibular pelvic ligament, that is the easiest method. And for posterior, this is for anterior approach. For posterior approach, you make a nick on the peritoneum 2 centimeter below and 2 centimeter lateral to the circle promontory, lift the peritoneum and cut it. Then once you open the peritoneum, do only finger dissection. Don't use any instrument that time, otherwise instrument will prick. and injure the vessel. Then locate the bifurcation, that is inverted Y, and inverted Y. Then recognize internal iliac artery as the medial structure, which does not cause any change in the femoral pulse. External iliac artery does cause change in femoral pulse. Then movement of your right angle or mixture forceps always from lateral to medial, never the reverse. Then careful not tying in the cavity. आप आर्टरी के सामने झुक जाओ, उसको उठाओ मत. Then two ligatures 0.5 to 1 centimeter apart. और one very important point, always do bilateral. लोग कहते हैं कि मैंने तो एक करा, एक करेंगे तो इफेक्ट भी आधा मिलेगा. Always do bilateral. Chances of free laparotomy and morbidity increases if you do single internal iliac artery ligation. This is from literature. And for beginners, first start opening the retroperitoneum in gynecological hysterectomy and take help from your surgeon friends. So this is my journey. Initially opening the retroperitoneum in gynae hysterectomy, then I observed 2 to 3 cases, then in obs case assisted 4 to 5 cases, then performed 3 to 4 cases under supervision of a surgeon friend, and then in obstetrics whenever it was required. It is preferable to take the assistance of senior colleague or surgeon friend. This is my patent model which I have got for that instrument. Thank you so much. Yes, ma'am.
Your practical points were very, very good. Especially one point that you haven't referred in your summary, that was the direction of the mixture when you are dissecting the fascia. Only dissect the fascia in the area where you are going to ligate. Don't be overzealous and don't try to dissect from above to downwards.
Exactly.
And the second point, that is the direction of the mixture. Don't poke it down and put it parallel. I think these two practical points were really golden words. And as practitioners, we know how important this is. And for juniors, the other point that you said, always see the bifurcation.
Yes.
Don't ligate anything without seeing the bifurcation. Palpate the femoral pulse and don't try to see the posterior branch. If you are just tying it